Hello everyone, my name is Yan Chen from the George Washington University. My presentation topic is accuracies of training levels of machine learning models, experiments on Delirium and simulated data. Some brief introduction. Data consistency and reliability are both challenges that arise in the context of complex health systems. There is considerable variability in clinical data, such as diagnostic codes, assessments, labs, and medical condition descriptions. Clinical data may be labeled or unlabeled. Even for the labeled data, errors or misclassification may happen. Supervised machine learning usually assumes the labels in the reference standard to be completely correct. However, weakly supervised machine learning, such as support vector machine (SVM), has been evidenced to accommodate incomplete and inaccurate labels. But there is lack of studies about the relationship between label accuracy and learning performance in both real-world and simulated datasets. So the aims of this study include to explore the relationship between label accuracy and learning performance in the context of a real clinical use case of delirium identification, which is commonly underreported and is documented irregularly, and to further explore the relationship between label accuracy and learning performance using simulated data. For delirium data, our study sample was drawn from the electronic medical records (EMR) from around 22 inpatients at a high risk of delirium from the VA External Peer Review Program (EPRP) program. The EPRP reviewers reviewed assessment and plan section of EMR and answered 5 questions associated with what was documented: a problem of delirium, a change in mental status, presence of confusion, presence of disorientation, and notation that the risk of delirium was assessed. Iterator reliability rates were calculated for the delirium study question in 2015 and 2017, as shown in the table. To build machine learning models, we only selected patients with at least one of the 3 types of nodes within 2 days before or after the admission date on record. These 3 types of nodes include H&P nodes, admission nodes, and emergency nodes. This left us with around 21,000 patients with about 23,000 H&P nodes, around 10,000 admission nodes, and around 42,000 emergency nodes. We split the datasets into 3 subsets: 80% for training, 10% for testing, and 10% for validation. We trained 3 models: logistic regression model, SVM with linear kernel, and SVM with polynomial kernel. Then we sampled an extra set of 100 documents from the EPRP corpus for expert review to estimate model performance. Both the figure and the table in this slide show the performance of our models. Look at these numbers. EPRP reviewers' annotation accuracy was only about 80%. However, regardless of logistic regression model or SVM models, their accuracy was around 87 to 88%, higher than that of EPRP annotation. This is an evidence for our hypothesis that weakly supervised machine learning models can achieve accuracy that is higher than the accuracy of training data. To confirm this hypothesis, then we conducted a simulated study. We generated the datasets for different scenarios based on 4 factors: underlying relationship between features and outcome. We have linear and nonlinear function. Error type, we have random error and systematic error. And error rate, we change it from 0% to 40%. And sample size, and we change it from 1,000 to 40,000. This is about how we set up our data. Here we provide the parameters about how we set up variables and formulas of determining true value of y. We created 100 random variables, including 90 binary variables and 10 continuous variables. To differentiate nonlinear relationship from the linear relationship between features and outcomes, we added 5 squared terms of randomly selected variables and 20 interaction terms between randomly selected variables. Random errors were defined as errors occurring randomly and not dependent on any condition. To generate random errors, we randomly flipped a proportion of true value of y according to the error rate. Systematic errors were defined as errors occurring depending on the value of certain features. To generate systematic errors, we randomly selected 10 features that were combined to determine where the true value of y should be flipped. We trained a logistical regression model, an SVM model with a linear kernel, and an SVM model with a polynomial kernel, respectively, using a set of simulated data as well as an ANSI gold standard dataset. Given the randomness of error assignment, we created 10 training datasets and then trained a model on 10 training datasets. The performance of the model was estimated as the average of accuracies on the test datasets. The model performance was estimated for each scenario. These figures show the accuracies of 3 models in different scenarios. When an error rate was at 0%, 5%, or 10%, accuracies were all in the range of 0.8 to 0.9, except for scenarios with the smallest sample size of n equals 1,000. As for the error rate of 20% and 40%, we added a reference line here. If the accuracy of a model was higher than the reference line, then it indicated that the model outperformed the accuracy of dataset, since the accuracy was larger than 1 minus error rate. So we found 3 models outperformed the accuracy of the datasets in many scenarios. Even the error rate were 20% and 40%. Besides, we also found that models were more sensitive to systematic errors and non-linearity. And SVM with a linear kernel outperformed logistical regression in general. The SVM with a polynomial kernel performed best on the data with systematic error, especially when the error rate was at a high level. So in both Delirium and simulated experiments, weakly supervised learning performed well on imperfect data. We can and should leverage big imperfect datasets, but we also need to carefully assess the nature of errors, linearity of data, and modeling algorithm. Having a very large but imperfect dataset may sometimes lead to a higher accuracy than having a perfect but a small dataset in terms of training. In conclusion, learning models can achieve accuracy that is higher than that of training data using both a real clinical use case and simulated data. The results of this study support the usefulness of imperfect data in clinical research via weekly supervised learning. So this is our acknowledgement. This study is supported by the VA and NIH. Thank you so much for your listening. So if you have any questions about this study, please contact me via this email. Thank you.